This is Dr. Howard Strassler with a Hints from Howard, a view to learn on restoration longevity. How long do restorations last? And I think we should admire the fact that our restorations do as well as they do in the oral cavity. Gosh, it's an Amazon jungle. Take a look at when you last placed some of the restorations when your patients come in for recalls. Let them know how long restorations are lasting, especially for those cases where you told them you didn't think they'd last very long because of the stresses they'd be under. So we need to alert our patients at the good job that we're doing. Did you know for orthopedic surgeons, for hip and knee replacements, that the chance of a hip or knee replacement joint will last 10 years is 90 to 95%? In fact, the chance that these joints will last 20 years are 80 to 85%. Are our restorations doing as good? In fact, in a study of dental materials and longevity of restorations placed in public health clinics in northern Sweden, we saw the median age of an amalgam was 15 years. The median age of a composite was only 5, for a glass ionomer 9, and for a metal ceramic crown 14. So when we take a look at this median age of 6 years between dentists with 14 years or less of experience and dentists with greater than 15 years, Class 2s lasted the shortest, Class 3s the longest. In fact, when we look at survivability of Class 2 restorations and we compare, composite resins are about have about twice the failure rate over time, a mean failure rate, when compared to amalgam. I'm not saying switch to amalgam, but I'm telling you that we need to do our composites better later. In fact, when we look at longevity of composites, the median composite longevity, the median is 6.2 years. I think we can do better. The risk factors of what we're doing that put our restorations at risk are adhesive placement techniques. We need to do better. Control of the treatment field, isolation from saliva and blood. Placing our restorations on enamel will give us longer lasting results than on cervical margins ending on dentin. The longer we take to place the restoration, the greater risk for contamination during the different steps. In fact, perhaps bulk fill composites make better sense. And using good, sound, adequate light curing techniques, curing our composites. When we look at our patients put our restorations at risk. A risk to caries, patients who have high caries risk, restorations won't last as long. Our patients who have parafunctional occlusal habits, that occlusal stress risk leads to restoration fracture and is probably the second leading cause for why restorations don't last longer. And then our patients need to be attentive to their recall appointments and come in based upon what their needs are. High-risk patients for caries perhaps need to come in every 6 months. Very low-risk patients perhaps once a year, once every 2 years. So let's see how our restorations age, and you'll be looking at restorations that I placed and documented over time. For this Class 3 composite resin restoration for a patient who's smoking a pack of cigarettes a day, this restoration at 12 years is still surviving. A little bit of marginal staining, some discoloration. In fact, if this were on the facial surface, it would probably be aesthetically unacceptable to the patient. Or this occlusal restoration on the second molar. It's 9 years old. You can see where. Especially on the distal, where the patient has a cuspal contact. And you can also see where into the dentin. And this patient also has a parafunctional habit. So these are changes that we would expect. In fact, when we look at posterior composites, and they're at the greatest risk of needing replacement sooner rather than later, the design, the size of the cavity preparation, the larger the preparation, the increase in the occlusal wear. The replacement of cusps also enhances wear, looking at perhaps some of the CAD/CAM ceramic restorations when cusps are involved. But yet composites can last a long time. In this case, the isolation was done with just cotton rolls. Facial restorations to mask the white spots, cavity preparations on the facial into the enamel restored with a microfill composite. And we look at this composite at baseline and then 17 years later, and if you look carefully, you'll notice some surface changes to the facial due to toothbrush toothpaste abrasion, that the restorations flattened out from its more rounded surface during original placement. But 17 years isn't too bad. In fact, when closing a diastema using a microfill, we can place these restorations at baseline, and for a patient who uses Listerine twice a day, uses a whitening toothpaste, you can see surface changes to the composite. If you look at the baseline and the shape of the diastema closure, you look at the shape and surface of the composite, you'll notice at 5 years we have a change to the median, the interproximal contact. It gets wider. You can see that the composite's changing color and shade, staining, picking up surface, environmental damage. And then at 20 years and 13 years, you can see on the surface some porosity as the composite's wearing. The composite was not this flat, but through normal toothpaste and toothbrush abrasion, we see some surface changes. But still, the enamel bonding still performing quite well at 20 years. Or for these composites on 7 and 10, using once again a microfill composite to restore peg-shaped laterals, these composites look pretty good. These are directly bonded to the enamel. Today, in many cases, practitioners are going to use 3/4 porcelain veneers over these peg-shaped teeth. In this case, we used composite. These were placed in 1983. And when we look at these two restorations 25 years later, they're still doing very well. On the mesial facial, on both 7 and 10, you'll notice some staining. That's staining actually on the enamel and not the composite. But not all composites fare this well. For this patient who's a pipe smoker, we've done some direct bonding with a hybrid composite resin, and when we look at this hybrid 2 years later, he's still smoking his pipe. He uses a smoker toothpaste to keep the stain off his existing teeth, and you can see the damage he's done to this composite resin. And over time, the oral environment takes its toll on composites, but as practitioners, sometimes we can take the blame. On the left-hand side, the marginal staining is composite overlapping unetched enamel. That can be smoothed away and the stain removed with a polishing disc. Or these class 5s on the middle image. You can see these composites are not well bonded, and these are enamel surfaces. This is a technique issue. And certainly that patient who had the facial composites, who was a pipe smoker, who is really tearing up the surface of the composite with his toothpaste, his abrasion habits, and his smoking. We can also look at other things that we can do with composite. Fiber-reinforced composites for periodontal splinting. For this patient who has significant periodontal disease and a compromised dentition, these teeth have grade 2 and grade 3 mobility. We have 80% bone loss on the 2 mandibular central incisors. We do a thorough scaling and root planing and polishing. We place a fiber splint. Now, will that splint improve these teeth's prognosis? And that's what we're going to see. Because 7 years later, and this is when the patient showed up for their recall appointment, you can see these teeth are still in function. These teeth will need scaling and root planing and polishing. The patient's still smoking cigarettes, but yet you can see the improved prognosis from placing one of these rib-on splints. In fact, we can use the rib-on for doing natural tooth pontic bridges or creating a composite pontic. You wonder what's holding this central incisor in place. And the day we extract that tooth, we do an immediate natural tooth pontic fiber-reinforced bridge using rib-on THM. And here's the placement of the pontic with the natural tooth that day. How's this going to hold up over time? What will be the prognosis of this restoration? And we see 36 months later it's doing quite well. We've improved the prognosis for this patient. But we're also doing bonded restorations with porcelain. And when we take a look at Mark Friedman's 15-year data back from Compendium in 1996, he looked at 245 porcelain veneer failures. In fact, fracture was the greatest cause of failure of these veneers. 22% had micro-leakage, leakage underneath the veneer, 11 with a veneer debonded completely. And he was tracking at the time approximately 1,000 veneers. And we take a look at a couple of his failures where the fracture and the debonding, certainly in incisal edge. And what he found is that many of the debondings related to the veneers placed on dentin and not enamel. You can see on this class 5, due to the forces that cause abfraction, the veneers popped off and fractured at the cervical third. But porcelain veneers can do quite well. If they're bonded to enamel, we follow good, sound clinical techniques. For these long-term cases of porcelain veneers that I placed, and I've been placing veneers since 1984. In fact, I have some veneer cases significantly over 25 years. Here we close some diastemas. We did a minimally invasive preparation, and we look at the veneers a week after placement. Now we look at these same veneers at 24 years, and what you can notice is a little bit of recession. We can see some plaque and a little bit of staining on the porcelain itself and on the tooth structure, but doing quite well after 24 years. Or this porcelain veneer case for a patient with enamel defects. And this is a patient who was 16 years old when these veneers were placed, something I wouldn't do today. But let's take a look at what happens over the 16 years. And this patient is a real bruxer. He really does work on those teeth. And so we look at the veneers at baseline, look what they are relative to the free margin of the gingiva. And then we look at these veneers at 11 years. And if you take a look at the canines, we've seen the gingival architecture has reshaped itself. We can see a cervical lesion occurring, whether it's due to toothbrush abrasion, erosion, or perhaps a combination with abfraction. His occlusal habit's still there. And then we look at these veneers 24 years later. The veneers are doing quite well. It's just that it's time for refreshing these veneers because of the patient's oral problems and the changes. But these are probably occlusally related. And then we ask the patient, does it bother you? He says, no, I'm fine with this smile. The teeth are white, the teeth look good, but in some cases, if we replace these veneers, we have to consider if the veneers extend on this cervical third, will they be at risk of fracture? Or for this patient, these are composite veneers that I placed 10 years earlier. The patient has tetracycline staining. These are microfill veneers. You can see that same pitting that I showed you earlier in the composite over time due to wear. Some surface changes. But the patient is now ready for a better restoration, one where the color is whiter. We remove these composite veneers, exposing the tetracycline staining. We do a minimally invasive preparation, and we place some porcelain veneers over the maxillary incisors to the premolar and first molars, both maxillary and mandibular arch. How well would these veneers do? Well, here we're looking at these veneers 18 years later. They're doing quite well. Because the patient's older, we can see that around the anterior we don't see a loss of free margin gingiva, no recession in these areas. They're reasonably stain resistant and they're holding their color. So this was Dr. Howard Strassler with Hands from Howard on restoration longevity, why and how restorations fail, and things that we need to look at in our techniques.